This is Dr. Pablo Castañeda, and this is a brief review of the skeletal dysplasias meant for preparation for examination purposes. The amount and variation between skeletal dysplasias reminds me of Beatrix Potter's book, The Tale of the Flopsy Bunnies. In this book, she states that it is said that eating too much lettuce is soporific. Reading too much about skeletal dysplasias can be likewise soporific. However, this review is intended to make a brief and easy understanding. Dysplasia comes from the two Greek components, dys, abnormal, and plasis, formation. A skeletal dysplasia is an abnormal formation of bone, and over 250 kinds have been described. It would be impossible to go over them all in a review course. This shows the current classification system impossible to memorize. Therefore, it can sometimes be easy to use visual mnemonics. This classic painting by Velázquez can be seen in the Prado Museum in Madrid. It is called Las Meninas, and it highlights the young princess, the blonde girl at the center of the picture. However, if you look to the right, one of her maids-in-waiting clearly has a very characteristic facial expression, and it is clear that she has some form of skeletal dysplasia. The mnemonic common head fog is not meant to be the way you should end this lecture, but rather includes some of the most frequent kinds of skeletal dysplasias encountered: cleidocranial dysostosis or Apert syndrome, osteogenesis imperfecta, Marfan, mucopolysaccharidosis, Olier's or multiple enchondromatosis, neurofibromatosis, hypochondroplasia, multiple hereditary exostosis, achondroplasia, Down syndrome, fibrous dysplasia, osteopetrosis, and Gaucher's disease are some of the most commonly encountered syndromes in clinical practice. My diagnostic approach in clinic is to determine that something is not quite right, determine if it is acquired or congenital, determine if it's on my short list, the common head fog, then take a look at a genetics book, my favorite is Tybee and Lachman's, to confirm the diagnosis, but ultimately refer to a geneticist. Now, for the purposes of examinations, there are no shortcuts. You must memorize the following tables, which will summarize the most frequently encountered skeletal dysplasias. First, we will start with autosomal dominant. Achondroplasia is by far the most common skeletal dysplasia, caused by a G380 mutation of the fibroblast growth factor receptor 3 on the short arm of chromosome 4. It results in an inhibition of chondrocytic proliferation. Apert syndrome is a similar gene, however it is the fibroblast growth factor receptor 2 that causes the inhibition of chondrocytic proliferation. Charcot-Marie-Tooth, in most cases, can be linked to a mutation in the PMP22 gene, resulting in nerve demyelination. Pseudoachondroplasia is caused by a mutation in the COMP gene, again resulting in abnormal cartilage formation. Spondyloepiphyseal dysplasia congenita, or SED, is caused by a mutation in the COL2A1 type 2 collagen, resulting in a defect in cartilage matrix formation. Neist syndrome is caused by a mutation in type 2 collagen. Continuing with the autosomal dominant dysplasias, multiple epiphyseal dysplasia type 1 is caused by a mutation in the COMP gene, resulting in an alteration in type 2 collagen. Multiple epiphyseal dysplasia type 2 causes a disruption of type 9 collagen. Jansen's metaphyseal chondrodysplasia is caused by a mutation to PTHRP, which results in a functional deficit in parathyroid hormone. Schmidt's metaphyseal chondrodysplasia affects type 10 collagen. Cleidocranial dysplasia is a point mutation in the CBFA1 gene, resulting in impaired intramembranous ossification. Osteogenesis imperfecta, type 1 and 4, which are autosomal dominant, are caused by mutations in the COL1A1 and 2 genes, resulting in alterations in type 1 collagen. The most commonly tested autosomal recessive dysplasias are diastrophic dysplasia, caused by a defect in the sulfate transport protein, which causes a defect in sulfaction of proteoglycan, Friedreich's ataxia, caused by a defect in the frataxin gene, osteogenesis imperfecta types 2 and 3 should be noted to be recessive. McCusick's metaphyseal dysplasia has an unknown pathogenesis. X-linked recessive dysplasias include spondyloepiphyseal dysplasia tarda and the few remaining cases of Charcot-Marie tooth, specifically affecting the so-called connexin gene. The orthopedic aspects that should be remembered for patients with skeletal dysplasias include looking at the spine for instability, kyphosis, scoliosis, and stenosis, and the extremities to determine the presence of angular deformity and hip dysplasia. By far, the most common form of dwarfism or skeletal dysplasia is achondroplasia. We can go back to this incredible painting by Diego Velázquez, which shows the facial characteristics, but also the body habitus of a typical patient with achondroplasia. Again, this is the most common skeletal dysplasia. It is autosomal dominant, and clinically, patients can have spinal stenosis, and a pathognomonic sign is having a decreased interpedicular distance from L1 to S1. Significant differences can be found with Morquio's syndrome, which is what this other person from another Velázquez painting is thought to have had. The difference here is this is proportionate dwarfism, whereas achondroplasia is so-called rhizomelic dwarfism. Morquio's is a mucopolysaccharidosis. It is autosomal recessive and can be associated with cervical instability. An atlantodens interval greater than 3.5 millimeters is considered unstable, but more than 10 millimeters is an absolute indication for surgery consisting of stabilization. It should be noted that the so-called space available for the cord can be significantly decreased in these patients without causing significant clinical impairment, but an indication for surgery is a space available for cord less than 5 millimeters. Another difference between Morquio's syndrome and achondroplasia is the fact that Morquio's patients tend to develop genu valgum, whereas achondroplastics tend to develop genu varum. It should be noted that enzyme replacement therapy has prolonged the life expectancy for patients with Morquio syndrome, but has not had a significant effect on the natural history of the musculoskeletal manifestations. Thus, clinicians should be acutely aware of the spinal, extremity, and hip consequences of having these conditions. One of the most commonly recognized is late hip dysplasia, which is refractory to brace treatment and, if persistent, requires surgical correction. Good luck!